James Anchor, and I serve as the president of the Boston Medical Library. Firstly, thank you all for coming on a beautiful evening like this. In 1803, John Collins Warren, James Jackson, and some of the others started the Medical Improvement Society. They met to discuss papers regularly. With their collection, they incorporated the Boston Medical Library in 1805. It soon went into disuse by 1826. Things were happening across the globe in medicine. Rudolf Virchow was publishing his archives in Berlin in the mid-19th century. The cellular theory, leukemia cell, the process of thrombosis, embolism, and public health infections, lots of stuff. And we didn't have a library here. Right here in Boston in 1846, surgical anesthesia became a reality. And again in Boston, all the mental homes linked hand washing to reducing puerperal sepsis in 1843, more widely publicized, as we all know, by the Austrian-Hungarian Semmelweis from 1847. But everybody rejected that at the time. Later, Louis Pasteur helped establish the germ theory, leading to Joseph Lister's antisepsis in Scotland by 1867. And Robert Koch was advancing bacteriology and sterilization. Surely, Boston needed a library. Through young James Chadwick, who just returned from Europe, the current Boston Medical Library opened its doors on Monday, October 18, 1875, with Dr. Oliver Brenner Holmes as president. And in 25 short years, the BMM built their own building at 8 to Fenway, which became a famous address. And this is the building where it was just built in 1901 or thereabouts. And soon after that, the Harvard Medical School moved from its place in Copley Place to the quad that you see here where we are in 1906, and found it was frustrating for them to have to go to the Fenway for a larger collection because this is the BMR. In 1958, when the Countway Charitable Foundation enabled the creation by 1965 of the Countway Library for the combined housing for the collections and services of the Harvard Medical Library and the Boston Medical Library. The BMR's current and historical collections of rare books, paintings, artifacts, prints, they all moved to the Countway and created one of the largest and most valued collections under one roof. And today, Chadwick would be proud to see the collaborative efforts of the Boston Medical Library, the Harvard Medical School, and the Mass Medical Society to continue to expand the horizon from the ancient to the current to a future, including all the changes we see in information technology, bioinformatics, and all the rest. To be an active resource, reaching out to help the learning of the profession through its entire life cycle, from the medical student, teacher, and researcher to the physician, caring for one patient at a time in her office, struggling to find the time to learn the best way to do what she knows to do best. Through all this, the BML never swerved from her original mission to improve medical care, and in the process, celebrating the history of the profession's continual struggle to do so, captured in her motto, served et docet, to preserve and to teach. With that introduction of the Boston Medical Library, it's indeed an honor for the Boston Medical Library to present the 14th J. Worth Estes lecture in honor of our late trustee, Dr. Estes, under the leadership of our committee chair, Dr. Dale McGee. Thank you, Dr. McGee, for doing all this, your committee, and historian, and no less, Gillian Silverberg, who is here, without whom all this wouldn't have happened, putting all this together. What about the person of whom we named the lecture? Dr. Estes was an accomplished historian, a professor emeritus of pharmacology and social medical sciences at BU, and his publications included not only academic in hematology and pharmacology, as well as a wide range of topics in the history of medicine. And thanks to his late wife, Cindy Estes, for having funded our former president, Dr. Leonard Morse, for establishing the J. Worth Estes Memorial Lecture Series. Please welcome Dr. Carol Walsh, Professor of Pharmacology and Experimental Therapeutics at BU Medical School, and a mentee and later a colleague of Dr. Estes, who sent you.
Thanks very much to all of you who have come to celebrate Worth Estes' life and work. Many of you in this audience, I've learned, knew Worth Estes personally, and I'm sure you share with me the special joy of thinking about Worth, thinking about his personality, thinking about his remarkable accomplishments as a medical historian. I met Dr. Estes in 1967 and was very grateful to be a student of his and eventually his colleague for many, many years. Some of you may not be aware that Worth actually was raised in Lexington, Kentucky. He was raised by a family of journalists and psychologists. That interested me in part because I'm aware and just learned from some of our colleagues here that he was a wonderful mentor for women as well as male students. He served for 30 years or more as professor of pharmacology and led the pharmacology curriculum at BU Medical School, where he had earned his master's and MD degree in 1964. As a leader of the training of students in pharmacology, he was a dedicated educator. And we learned pharmacology from him as well as the skills of being an educator. His passion for the study and scholarly achievement in medical history was renowned. And he served in many capacities, including leadership positions for the American Association for the History of Medicine, and as editor of the Journal of the History of Medicine and Allied Sciences. Worth published many books and many articles in a wide ranging of fields, different eras, different cultures, ranging from ancient Egypt to naval medical practices in the Portsmouth, New Hampshire area. His passion also, in addition to scholarly work in medical history, was the care and nurturing of libraries. He was devoted to the Countway Library. He was very grateful for its resources and especially for the people that he met and worked with through the Countway Library. So it's a fitting tribute to Worth that we meet here in close proximity to the Countway Library and welcome a colleague of Worth's, Professor Nancy Tomes, who knew him through his work as a medical historian, and in fact reviewed some of his texts and publications. So thank you, Professor Tomes, for joining us this evening. And she will be introduced by Scott Podolsky. Thank you, Scott.
That's great. So it's a real privilege to get to introduce the Sears J. Worth Estes lecturer, Dr. Nancy Tomes. Dr. Tomes obtained her BA from the University of Kentucky before obtaining her PhD with Charles Rosenberg at the University of Pennsylvania and started a remarkable career at SUNY Stony Brook. Her first book, The Generous Confidence, Thomas Story, Kirkbridge, and the Art of Silent Keeping, was a groundbreaking look at the origins and ultimate limitations of the asylum system, relying in part on cat resources sources. And we followed closely by her and the Yarrow's Madness in America, Medical and Cultural Perceptions of Mental Illness before 1914. But about being self-centered, read her next book, 1998's The Gospel of Germs, Men, Women, and the Microbe in American Life. That was released just as I was deciding to pursue the history of medicine. That obviously shaped the direction of my own research in the direction of the history of infectious disease. And more importantly, it would shape more general understanding of the relationship between medicine and society in which it's embedded. The Gospel of Germs, looking at the intersection of medicine, culture, and commerce, would garner the American Association for the History of Medicine's, AHM's, William Welch Award, this most prestigious book award, as well as the History of Science Society's Watson Davis Prize. It will set the stage for her further work at the intersection of patients, medicine, and commerce on an even broader and longer scale. Dr. Thompson delivered the AHM's 2004 Garrison Lecture on the American Medicine Show Revisited, focusing on the prevalence of ballyhoo in the advertising of over-the-counter remedies, prescription drugs alike. And she would become the president of the AHM 2012-2014. In 2016, along these lines, UNC Press published her most recent book, Remaking the American Patient, How Madison Avenue Turned Patients into Consumers, and it's an absolute must-read. For anyone who thinks that patient consumerism is a recent phenomenon, Dr. Thomas turns this notion on its head, tracing the capacity of lay people to stand back, examine, and critique medical care from the 19th century onward. And yet, while such consumerism has been at times empowering, Dr. Thomas demonstrates how organized medicine, the pharmaceutical and drugstore industries, and advertising are all growing in tandem, and demonstrates the degree to which sources of medical information to the public and clinicians alike have borne the imprint of particular and often commercial interests and biases. It's a powerful and sobering message, and Dr. Thompson and her book were awarded the 2017 Bancroft Prize in American History and Diplomacy, the most prestigious historical book award in the country. So you're in for quite the treat. The Great American Medicine Show lecture is one of my favorites of all time. And Dr. Thompson's recent book is amazing, so I'm particularly looking forward to hearing her speak on the patient as well as her historical perspectives on patients' roles in healthcare quality initiatives.
Okay, can you hear me all right? Yeah, good, good. Well, thank you so much for inviting me here tonight, and thanks to the weather gods for letting me get here this time. It's an honor to give the 2018 Worth Estes Lecture, especially since, as Carol pointed out, he was a good friend and colleague to me. As you probably know, there is an enormous policy investment today in efforts to teach Americans to use data about quality measures. For example, rates for mortality or readmission following common procedures when they go to pick a physician or a hospital. This effort is part of a broader approach known as continuous quality improvement that has come to dominate in American medicine since the 1980s. Now, initially, much of the CGI movement focused on physicians, trying to get them to focus on outcomes of care. But in the mid-1990s, this effort broadened to include patients as well, through the use of surveys designed to capture their perceptions of care. So my talk tonight is going to focus primarily on the patient part of this exercise. Of the patient-oriented efforts, perhaps the best known is the Consumer Assessment of Healthcare Providers and Systems, or CAPS, an instrument first introduced in 1995 to help standardize patient survey data so it could be used to compare providers and hospitals across institutions and health plans. And the goal here is to distill all these individual data points into a tool that patients can use to make better choices. It's a feedback loop. You collect the data, you crunch it to produce comparative indicators, and then you get a new group of patients to use those indicators to pick the physician and hospital that provides the best quality care. In this fashion, theoretically, we enlist an army of educated individuals to learn what those markers of care are, use that knowledge to reward the good and punish the bad. The invisible hand of the patient consumer will guide the healthcare marketplace in the direction of quality. What health economist Aaron Fratt terms, quote, the life-changing magic of choosing the right hospital or doctor, end quote, I kid you not, is supposed to be a formidable policy force. Yet for all the time, effort, and money that's been poured into creating these databases, their use has been limited. As of now, only 1 in 7 Americans uses available data about quality to choose a doctor or hospital. Now, maybe in an audience like that, that number is a little higher, but I bet it's still far from 100%. The United Hospital Fund just completed a major study trying to figure out why people don't use these expensive and carefully crafted databases. And what their researchers found was pretty depressing. Many of those databases were difficult to navigate and understand, and the quality measures they provided were often neither current nor able to address the individual circumstances that would lead a consumer to seek quality information. That's a quote from the report. The study concluded, again a quote, despite much hype, the age of the activated and information-empowered consumer who can drive markets toward high-value providers has not yet arrived. But meanwhile, the effort is to rework those tools to make them more consumer-friendly, and meanwhile, the wheels of data collection grind on. And I can attest to their persistence because I had a total hip replacement in July, and they are still after me to fill in that form, which, for reasons that will become clear to you out of stubbornness, I have not yet done. So what's going on here? Why do policymakers place such faith in this kind of data-driven exercise? Why do they think it will work? Why doesn't it perform as expected? And where does this approach fit in the larger history of healthcare reform? These are some of the questions I want to raise tonight. I come at this topic having spent the last decade and a half studying the history of medical consumerism, and Scott gave a nice summary. In fact, most people think it's going to be a very short history. Didn't the internet invent medical consumerism? I hear that a lot. In fact, medical consumerism has been around a long time, far longer than it usually acknowledged. I found enough material for a 422-page book in which the internet appears only in the epilogue. In fact, the belief that in order to get good care, you have to choose it very carefully goes way back in the historical DNA of the American patient. It was a defense mechanism adopted first in our snake oil, hang up your shingle and call yourself a doctor days of the 1800s, and it has evolved along with modern biomedicine. Compared to our developed nation peers, we have a more commercialized, monetarized culture of healthcare with comparatively weak medical gatekeepers and vastly more scope for health-related advertising. The rise of critical consumerism, the idea that the educated patient has to shop for care with a skeptical eye, was a product of that medical culture. Now, there are a lot of moving parts to this story, and tonight I'm going to tackle only one kind of narrow, and I'll apologize, it's kind of wonky, but I hope I can keep you awake. I am not going to focus on the complex negotiations that take place between individual doctors and patients, nor the role of so-called expert patients, people with a particular condition who seek more, who get information and try to have more influence, for example, in the conduct of clinical trials or creation of best practices, guidelines. These are important topics. They deserve their own talk. Instead, I'm going to take you down a wonkier road tonight to contemplate how patients as a category have been conceived of as actors in the making of healthcare policy. I personally am fascinated by the fact that while other, for example, European countries have taken up the cause of quality improvement, they do not rely on the big data cultivation of individual patients as connoisseurs of care, to borrow a phrase from a recent study. And I am this. What I'm working on tonight is part of a conversation I'm having with historian of medicine colleagues about biomedicine in the U.S. compared to Western Europe from the 1970s on, where we are kind of comparing notes about these kinds of developments. So tonight I'm going to offer you some of my thoughts on why it is that the United States has invested so heavily in this particular technology. But I'm going to start by looking first at how patients were envisioned as agents of change before the 1960s. And then I'm going to focus on the 1970s and more recent developments, specifically the way consumer choices became embedded in new schemes for using big data to make physicians and hospitals more accountable for both the cost and the quality of care they were delivering. And in doing this, I'm trying to engage with a growing scholarly literature on the rise of audit cultures in general and regimes of accountability that make college professors and just all kinds of people have to be assessed and meet indicators. I'm also reading a growing literature on neoliberalism and its economization of daily life, and trying to put medicine in that context. So, how has the role of the patient as watchbird evolved as part of this late 20th century professional managerial revolution in American medicine, as it's termed? So, as will soon become evident, while I am a true believer in the concept that healthcare needs to be more patient-centered, I have my doubts about the life-saving magic of relying on individual choice of doctors and hospitals as a way to push quality initiatives forward as the leading edge of quality control. As I'm going to suggest tonight, the patients must use databases approach came only after the failure of other more direct means of imposing accountability on far more powerful stakeholders. Likewise, the turn to big data, crunching numbers, and coming up with statistical measures to distill patients' experience reflects a long history of frustration with more direct ways of giving patients a voice in their own care. So I'm going to try to explain to you tonight how I came to these conclusions and see what you think. So let me start just with some terms. What do I mean by the phrase healthcare policy? In fact, that's a phrase that only comes into use in the 1960s. Today, the World Health Organization defines healthcare policy as, quote, decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society. Now, clearly, even though the term only pops up in the 1960s, deliberate efforts to identify problems in cost, access, and quality of medical care go back much further, at least a century. I think here of the Flexner Report, Ernest Amory Codman. This is to my friend Susan Reverby, who wrote a spectacular paper on the end result concept. And, of course, the Committee on the Costs of Medical Care. In 1966, Odin Anderson made just such a list in a very perceptive review of the history of American healthcare policy. But when I looked at Anderson's list, there was one striking aspect that jumped out to me, at least, and that is that prior to the 1960s, the only stakeholders involved in policy discussions were all experts. Physicians, hospital administrators, social scientists, and the odd government representative. The assumption was that lay people, or the patient public, lacked the knowledge to reflect wisely on the state of the national doctors' offices and hospitals. Now, this is not to imply that those experts involved in policy discussions didn't care deeply about the welfare of patients. They did. They just didn't think patients themselves knew what was good for them. And from the 1920s to the 1960s, policymaking followed the principles of what I think of as classic professionalism, based on medical autonomy and self-regulation. And the assumption was professionalism would ensure its own internal feedback loop of quality control. In other words, only doctors could watch over other doctors. The watchdogs wore white coats. I use the phrase watchdog. That's another interesting bit of terminology. According to the Oxford English Dictionary, this use of the term watchdog denotes a commission or other group appointed as a safeguard against abuses by the authorities in government, foreign policy, business interests, etc. This usage first appeared in the late 19th century in the political governmental context, and had become widespread in the United States by the 1920s in discussion of organizations such as banks and utilities. But it's only after World War II that that phrase watchdog starts to show up in discussions of medicine. Now, I titled my talk Watchbird. This is a variant I found in the 1970s applied only to patients. I don't know where it comes from, but to me it denotes the idea that of their comparative weakness. You know, a dog can bite, but a bird can only peck or cheep. Or it also reminds me of the canary in the mine. You know, the canary dies, right? So, watchbird, the patient as watchbird was a late variant on this concept of a watchdog. So until the 1970s, the policy assumption was that only doctors could watchdog other doctors. But it's important to note that this belief coexisted with a de facto recognition that patients needed to be educated to respect professional standards. Thus, even as the AMA was asserting its professional autonomy, it depended on convincing patient consumers that AMA-certified practitioners were the best choice. And precisely because the American profession's emphasis on free choice of doctor, precisely because of that emphasis, teaching the public what to look for to find a good doctor was essential. And such advice was ubiquitous from the 1920s onward. A layperson needed to pick a doctor who had gone to a good medical school based on Flexnerian metrics, was a member in good standing of the AMA, and steered clear of quackery. But herein lay the rub, and let me just summarize a little bit of the book's argument. In that, classical professionalism held that it didn't matter much which AMA-certified doctor the patient picked. High standards of professionalism guaranteed a uniform standard of care. But the American profession could not deliver on that promise. Doctors were unevenly educated. Some pretended to have more specialized knowledge than they did. Some cut ethical corners when it came to fees. Not only did their fellow doctors complain about these lapses, so too did a small but mouthy group of patients, starting in the late 1920s and going on to this day. Contrary to the myth of a golden age during which no layperson felt competent or entitled to complain about the quality of their medical care, I found a growing cadre of Americans, primarily well-educated, white, middle-class professionals who started even before the Great Depression to express skepticism about the profession's claims and to seek out more objective sources, as they would say, of information to distinguish the good from the bad. This kind of critical consumerism as I called it, envisioned the educated patient as a watchbird who should be listened to by the AMA, the FDA, and others vested with watchdog status where medicine was concerned. And in my research, I found their fingerprints over all kinds of policy efforts, including the reform of the FDA, both in the 1930s and the 1960s, the AMA's establishment of patient grievance committees in the late 1940s and 1950s, on and on. Yet, prior to the 1960s, the input of these watchbirds was marginalized and derided by policy experts both within medicine and the social sciences. Despite the fact that they depended on patients to be individual connoisseurs of care, most physicians had little respect for their reliability. Again, this is before the 1970s. I could provide many quotes to back this up. I'll just use one of my favorites from Walter Alvarez. Alvarez was an internist critical of his profession's shortcomings who believed in educating the public. He wrote a popularly syndicated newspaper column that gave advice, for example, about how to pick a good doctor. Yet Alvarez did not see the public as a dependable ally in reforming medical care. And he chastised his colleague, the popular science writer T. Swan Harding, in a letter saying this. I think, and Harding was very much a consumerist, I think you make a big mistake in thinking, as you seem to, that the average layman will have higher ideals than we have. And he pointed to how under the new Nazi regime he was writing in the 1930s, quacks were being boosted into high positions. But here's my favorite line. If you want to find a lot of half-cracked people who, when they are ill, are particularly fond of going to chiropractors, osteopaths, and Christian Science practitioners, go to a university town. Still, there was a proxy of sort for the voice of the educated patient in this pre-1960s policy discussions. They were the doctors without the white coats, the PhDs. From the late 1920s onward, a growing number of economists, sociologists, eventually even anthropologists, started to specialize in medicine and its problems. Their legitimacy as experts rested chiefly on their ability to generate seemingly objective data about what so-called John Q. public was doing and thinking. For example, the anecdotal and statistical data they produced for the Committee on the Costs of Medical Care is a great example of this. The collection and analysis of objective information about patient experiences was a critical part of their policy labor. As Odin W. Anderson put it again in his 1966 retrospective, the United States is a fact-loving nation. But that information remained scattered and uneven. Its usefulness was undercut by ideological battles over preserving medical professionalism. As Anderson put it, facts were gathered for use as brickbats to throw at a policy adversary, or as a armor, fragile at best, to defend one's positions from the brickbats thrown from another policy position. This was the state of affairs in the late 1960s, when the convergence of rising expenditures, political battles, policy debates, and information revolutions ushered in a new era in which defining and representing patient consumers' interests became a much more central theme of health policy making. Now, this is a context that I think is familiar to you, so I'm going to mention it only briefly, but the real trigger here is, of course, the creation of Medicare and Medicaid, which began a huge public investment of taxpayer dollars in healthcare, as well as generated mounds of data that, with the advent of computers, could be collected and analyzed. The new public funding worsened an already significant inflationary cost spiral that had begun with the spread of voluntary health plans before 1960. And as costs skyrocketed, so did a familiar set of questions. We are spending more money, but are we getting our money's worth? Simultaneously, the faith in experts to answer those questions declined precipitously, particularly in the wake of the Watergate scandals. In the 1970s, a baby boomer generation of policymakers imagined that by restoring power to the people, as they thought of it, change would bubble up from below. An army of motivated citizen patients would take on the new medical industrial complex and fix its many sins. In his 1969 presidential address to the American Public Health Association, Lester Breslow, who was an MD with an MPH, acknowledged that the professionals' world is being shaken. In his words, the inner-directed health agency, where the consumer has little voice, is threatened by the community forces recently set in motion. In this new era of consumer empowerment, experts could no longer expect deference because of their technical competence. And this power to the people concept intersected with a new, at the same time, with a new determination to make physicians, hospitals, and hospitals more accountable for their economic and therapeutic performance. In a long 1978 article that in Medical Economics titled, "What Does Society Really Want from Doctors?" Greater accountability is the answer. Richard Peck described the new climate in these words. A doctor used to be accountable to his patient, his hospital, and his local medical society, and that was that. Today, he answers to far more inquisitive government officials, revitalized licensing authorities, and to a small but growing extent, big business leaders and consumerists. Peck explained that the new demands for accountability were the product of three forces. These are his words, increased government financing of healthcare with the rise of double-digit inflation, a growing belief that the healthcare system is out of step with a free enterprise economy, greater public demands of a schizophrenic sort, as he described them, demands on the one hand for the latest medical miracles side by side with, quote, patient doubts that doctors know what they are doing. Does this sound really familiar? Yes, it does. And the key to all of this, he concluded, is the doctor. Now, not surprisingly, the first efforts at bringing a new regime of accountability started by trying to strengthen the feedback loops of traditional professionalism, of empowering doctors to watch over their peers. And for example, the 1972 amendment of the Social Security Act required the creation of professional service review organizations, new physician watchdog bodies that were tasked with rooting out unnecessary care in programs being funded by Social Security, Medicare, and Medicaid. A parallel initiative from the 1970s required the creation of regional health care planning councils to oversee the expansion of hospitals and other medical facilities. So constructing a new building or acquiring a new piece of medical technology required filing and obtaining a certificate of need that these bodies of experts had to approve before that work started. Other more radical forms of accountability consisted of getting patient consumer representatives into institutional decision making. Starting in 1963 with the Community Mental Health Act, federal laws during the Great Society began to require citizen representation, later they would call it consumer, on review boards of agencies that receive federal funds. The Organization for the Economic Opportunity developed the mandate to include, for example, maximal feasible representation of those receiving a service on the governing boards of an agency. Citizen involvement was a cornerstone of the National Health Planning and Resources Development Act, passed in 1974 and revised in 1979. But on both these fronts, the experts, the doctors watching doctors, the other expert, and also the citizen watchbirds, the results from these initiatives were disappointing. I don't have time to go, this is really far wonkier than even I can bear, but those PSROs and regional planning councils ran into enormous resistance. They did indeed set up, but it was very difficult for them to actually either get down costs or get a uniform standard, even agree on what a uniform standard of quality was. They did not, meanwhile, simply including consumers on planning boards did not result in miraculous improvements in planning rationality or lower healthcare costs. Consumer boards tended to end up serving as rubber stamps for better organized interest groups on those boards. When they did try to act more assertively, they ran into enormous resistance. Now, it's in this context of measures that don't seem to be working that the concept of turning to large data sets and using computers to analyze them started to emerge as an alternate way to try to capture patient experience and make it count. Starting in the 1970s, integrated circuits and miniaturization made possible a new generation of computers, including supercomputers capable of processing huge amounts of data and mini computers able to process smaller amounts for the use of individual researchers. With each passing year, computers got smaller in size, larger in memory, faster in operation, and easier to operate. And they could be linked into networks to exchange their data. Healthcare institutions were among the first to generate what are now called big data sets, large and complex data sets that required machine intelligence to analyze them in a meaningful way. In every realm of healthcare, including hospitals, physicians' practices, and third-party insurers, needed records to transact both their therapeutic and their economic business, so as that data started to accumulate and to raise new possibilities for computerizing it. This computer revolution facilitated the spread of a new kind of systems-oriented thinking that arrived in medicine starting in the late 1950s, early 1960s. It's part of a budding romance with engineering that would help transform medicine into biomedicine. You may have heard of Avitas Donabedian, physician and public health professor at the University of Michigan, came up with a method for linking structure, process, and outcome to measure quality that was seemingly tailor-made for electronic data collection and analysis. The convergence of this systems thinking and the new potential of computer-assisted technologies spurred the growth of what we know today as outcomes research. And in the late 1970s and early 1980s, researchers began more rigorously to try to attempt outcomes related to particular procedures as well as sentinel events that suggested lapses in care. And I'm just looking at the David Rutstein papers at the Countway, because he's very much involved in that. As might be expected, these assessments uncovered many areas in which providers and hospitals were not performing either consistently or well. Again, you're probably familiar with Jack Weinberg's work on practice variations that suggested that despite their standardized training, physicians in different communities practice medicine in highly variable ways that could not be explained by the characteristics of their patient populations. Now again, initially this kind of research was not envisioned as a means to identify and discipline individual physicians or hospitals, nor to be used by patients, but it was rather to find out the reason for practice variations so that the profession could fix it through medical education or professional guidelines. But here another development, so-called managed competition, emerged to take that outcomes research in a more economic, neoliberal direction. By linking payment systems to the pursuit of greater cost effectiveness and quality, the American healthcare system could be dramatically improved. That was the hope. New forms of outcomes measurement and management were essential to this restructuring. As Paul Elwood explained in a 1988 article, outcomes research constituted a, quote, technology of patient experience, end quote, that could be used to improve healthcare delivery. And the managed competition movement became an important conduit through which the idea of informed patient, informed choice formulation started to come into policy thinking. Outcomes research certainly envisioned their work as helping the patient consumer, but their findings were primarily aimed at elite policymakers and not patients themselves. But as other more forms of consumer action seemed stymied, the appeal of institutional transparency, of opening up these giant informational storehouses to the public, started to take on new appeal. In the 1980s, this new politics of transparency played out in dramatic fashion with the Healthcare Finance Administration. As the government body charged with overseeing taxpayer-funded services delivered through Medicare and Medicaid, HCFA was an obvious target for a disclosure strategy. Already by 1973, its information database was substantial enough to attract the interest of the Public Citizens Health Research Group, one of the main consumerist groups, which tried through congressional petition and lawsuits to have that data released to the public with no success. As Sidney Wolfe lamented to a Washington Post reporter, quote, "We meet every kind of resistance you can imagine to the public's right to know," end quote. But with growing pressures for economic reform and consumer empowerment, or economic reform through consumer empowerment, the idea of publicly disclosing HCFA data started to gain more traction. By 1981, the prestigious Institute of Medicine endorsed the public disclosure of hospital mortality data to, in their words, enhance consumer choice and force medical institutions to have, in their words, public accountability. In 1986, then Secretary of Health and Human Services Otis Bowen appointed William Roper as HCFA's head. Both Bowen and Roper were political conservatives appointed by Reagan as well as physicians, and the idea of accountability appealed to them. Roper ordered his staff to prepare a preliminary study of mortality data for 142 hospitals. He never intended to make that report public, believing that the data would be too difficult for the average American to interpret. But the New York Times heard of the study and announced its intention to sue under FOIA for its release. And at the advice of HCFA's legal counsel, Roper released the report in December 1987. Now, this report got extensive coverage in the news media, especially the names of local hospitals that got bad grades. Observers immediately pointed out the many flaws of the data, the same flaws that had made HCFA officials reluctant to release them in the first place. For example, the data analysis could not sufficiently correct for how seriously ill a hospital's patients were. The sicker the patients, the more likely they were to die, and thus to make your mortality rates look bad. Yet for all the reservations, this data release was hailed as, this is a quote from the Washington Post, a revolutionary first step in giving consumers an objective measure of the quality of care in individual hospitals. Jack Christie of the American Association of Retired Persons Public Policy Institute celebrated the fact, he said, "We're finally cracked the reticence, the guild protective mentality that has denied the public such useful information." Now let me just note here this enthusiasm was a bit premature, as evidenced by the less successful attempt to prise open the public coffers of information about problematic physicians. Those data sets also had been collected by the AMA and many state medical boards for years. They wouldn't even share them with other physician credentialing bodies. Thus, doctors convicted of malpractice who lost their license in one state could easily move to another. As the number of malpractice cases started to go up, congressional conservatives and liberals found common cause in wanting to crack down on bad doctors. So in 1986, Congress passed the Health Care Quality Improvement Act, which set up the National Practitioners Data Bank and required malpractice insurance companies, state licensing boards, and other organizations to report cases of negligence and incompetence to it. But unlike the HCFA, this stayed closed to patients. In the end, the law exempted the data bank from the terms of FOIA, so you cannot FOIA that information, and limited its use to hospitals, state licensing authorities, and professional societies. The Health Research Group also challenged that. They lost in court on the grounds that a physician's right to privacy was more important than the public's right to know. Now, Public Citizen did get itself a seat on that board and used that data to try to create its own bad doctors lists. But you can see there was definitely a difference when it came to disclosing information about individual doctors. These public data dumps were only part of an information revolution underway. And here I want to just turn briefly to the private side of the story. In that, private entrepreneurs quickly realized that providing the public with information about hospitals and doctors could be very lucrative. And they claimed they could do a better job of it than these big lumbering federal agencies. The trendsetter in this regard was U.S. News and World Report, which began in 1990 to publish a special consumer's guide to hospitals, patterned on the measures that it developed to produce college and law school rankings in the 1980s. And this was basically used to come up with a list of the best hospitals. By distilling evidence of an institution's reputation into a very easy rating system, U.S. News said it offered its readers news you can use. And even though the print version of U.S. News has gone under, it survives online with through this ranking of hospitals and colleges, of course. Best hospital lists soon gave rise to comparable best doctor lists created in similar ways. By the early 1990s, there were two different companies competing for the market and guides. For example, in New York City, one developed by a computer software analysis named Richard Topp, the other by a physician named John Connolly. So long before the internet, people were starting, and this is just when the internet was starting to come in and make this kind of exercise even more accessible. Thus, by the 1990s, we can see a cycle of information sharing, or throwing of brickbats, to use Odin Anderson's phrase, that continues to this day. Pointing to new standards of public accountability, many groups have sought to disclose and analyze big data sets generated by healthcare institutions, promising to analyze this data and turn it into information that patient consumers can use to make better choices. Yet this quest has inspired a now familiar cycle of criticism. The available data is always incomplete, it's difficult to interpret, hence you have to redouble your efforts to improve data collection and present its lessons in a more usable form. This brings us back to where we started with CAPS, the survey begun in 1995 under the Agency for Healthcare Research and Quality, a division of the Department of Health and Human Services. founded in late 1989 to do policy, healthcare policy and research. By the early 1990s, policymakers recognized the need to add more patient voice to the collection of outcomes data. Too often, policy changes were being driven by a desire for cost savings with no consideration for quality, much less patient satisfaction. At the same time, experts were creating benchmarks to be used in these studies for what constituted quality care without asking patients how they defined quality. So the time came in the 1990s, everyone agreed to add patients' experiences to the continuous quality improvement feedback loop. Some large health plans and healthcare systems had already begun to do that, but they were all using different survey instruments, and then you couldn't compare them. So the idea behind CAPS was to develop a single, well-constructed survey instrument that everyone could use, and then the results could be summed across many diverse sites of healthcare. Today, CAPS surveys, and I'm quoting from their website, cover topics important to consumers and focus on those aspects of quality that consumers are best qualified to assess, such as the communication skills of providers and ease of access to healthcare services. It does so, it certainly aspires to a higher level of objectivity and rigor than a U.S. News type ratings. Instead of ratings, which they consider subjective, confounded with attitudes toward the caregiver and non-specific, they focus on reports, which they define as more objective, easier to interpret, and that you can act on. CAPS started with a small group of participants and has grown steadily over the past decade and a half. On its 10th birthday in 2015, over 130 million Americans were enrolled in health plans that collect CAPS data, and over 3 million Americans complete those surveys every year. Still, for all the time and effort that's been put into fine-tuning and then mass administering CAPS, there remains resistance to its value as a policy tool. In part, that resistance stems from a continued skepticism that patient inputs about anything are trustworthy. 10 years into the CAPS experiment, and its advocates still feel the need to argue that case. Perhaps there is also a predictable disappointment that despite increasing the size of the data set and the sophistication of its analysis, big data and the service of quality improvement has not magically improved the whole healthcare system. It hasn't even produced greater certainty about understanding what consumers want and need. As my friend Mark Schlesinger and colleagues noted in 2013, quote, consumers' efforts to make sense of their healthcare choices remain a black box into which research has shined little light. So the answer is go back and do more research. And this is what Mark and his colleagues conclude. Research is needed to illuminate how consumers process multiple diverse pieces of information and what other information consumers consider when choosing a provider. So where does this all leave us? The long-term perspective suggests first that at least a minority of patient consumers have long been interested in educating themselves about markers of quality, and the consumerist movement in the 1970s was a definite prod to quality improvement, to the quality improvement movement in medicine. The turn to big data methods to capture patient experience came only after experiments with more direct ways of giving patient representatives a voice failed. But not surprisingly, the problems with the patient as watchbird have persisted in spite of this information revolution. Consider this irony, scouring 70-plus websites for quality information that patients might find useful. The United Hospital Fund researchers found that the only forms of easily available information about individual physicians were exactly the same markers that Americans were told to look for in the 1950s: the doctor's certification, medical education, and residency training. The list of what was difficult to find included whether your health insurance plan was accepted, whether new patients were accepted, the doctor's demographics, age, sex, etc., his or her hospital affiliations, languages spoken, legal actions taken, forget it, and malpractice. Not there. In the meantime, the for-profit sector continues to step up and try to give more accessible, although not necessarily more reliable information. And just as U.S. News discovered in the 1990s, there is a demand for less sophisticated but more usable ratings. You can go online and use ProPublica, Yelp, ZocDoc, or any one of a number of doctor rating sites that offer assessments that don't require an advanced degree to use. They present their own problems, and I'm sure you have some thoughts about that as well as I do. But from the consumer standpoint, the case for why Yelp is bad and the CAPS approved database is good is not so clear. Then there is the advertising. And again, I come back to commerce. For every dollar spent collecting and analyzing outcomes data, many thousands more are spent on clever advertising for individual hospitals that get you not to think about the quality at all, but just to go there because they're a hospital with a heart. In 2015, American hospitals, healthcare systems, and clinics spent $2.3 billion on advertising with taglines such as "Your choice for quality care, more science, less fear." How do you compete with that with a hard-to-use database? Here's another problem. We know patient consumers are not all the same, yet the use of decision-making tools tends to assume an educated consumer who is hyper-rational, good with statistics, has lots of time to wade through data, and has insurance that will cover the choices they end up wanting to make. As I suggest in my book, scaling up that model of an educated consumer that was based on white, middle-class college graduates has not worked well. It doesn't even work well for middle-class white people, much less all the other different diverse kinds of Americans that we have. It's even for supposed model consumers, white, educated, affluent, it can be difficult to execute this shopping model. Multiply by all the services and products you have to evaluate to be a good shopper. It's not just the doctor in the hospital, it's your drug, it's your long-term care insurance, on and on and on, and you are easily overwhelmed. The final point is the most obvious. The idea of bringing patient experience into the feedback loop reflected two big aspirations. First, that you could get everyone hooked into one giant quality-oriented system, and second, that once you identified problems, you would fix them. Both these requirements have not been met. At the end of the IOM 2001 report, Crossing the Quality Chasm, there's a fascinating appendix that explores the difference between mechanical and naturally adaptive systems and describes healthcare as a complex adaptive system that exists in a zone of complexity. Yeah. Well, we need this report. I suggest some more biological metaphors. I thought of David talking about the concept of evolution when I read this, how do we get to any kind of a survival of the fittest? We have no integrated healthcare system. Rather, we have many institutions, many stakeholders competing in a mixed market of public and private, for-profit and nonprofit providers. We do not begin to approach a continuous feedback loop. The second reality is that all too often the problems identified through analysis of patient experience are ones that we already know exist but have no will to fix. A case in point, one of these surveys of Medicaid users showed they don't have access to the services they need, period. More and better survey data is not needed to drive that point home. So where do we go from here? I have no good answers. I'm going to say that right up front. The reality is that even if I could think of a better way of using taxpayer money to improve patient care, there's no political will to enact it. We are stuck in a neoliberal management scheme with no exit visible. Thus, continuing on with the eternal quest for the better database may be the best we can do. And I will note that high levels of patient satisfaction do correlate positively with other markers of quality care, suggesting the watchbirds are kind of doing their job. And certainly the recommendations that United Hospital Fund group made, if anybody wants that, send me an email and I will send you the site to it. The recommendations they make should be put in play for more condition-specific, up-to-date information, as well as the inclusion of more narrative elements in databases aimed at consumers. People like stories, and that helps them to process information better than statistics. But the fact remains that it's hard for nonprofit quality control sector to keep ahead of the for-profit sector. Objective, consumer-oriented studies with no ulterior profit motive are underfunded and unappreciated. There is resistance to the bureaucratic labor and quality control and performance indicators. Providers certainly hate doing it. I hate doing it. I know it's one of the big beefs that doctors have with the Affordable Care Act. There's the new tsunami of paperwork. And when costs are always a concern, here's a good target. Excessive, this is a quote, excessive administrative costs due to measurement and associated activities cost about $190 billion per year. So why not save that money? The low priority, I think, for this work shows in those out-of-date results. Some stakeholders may feel a vested interest in keeping it that way. In the meantime, the for-profit competition for patients' consumers' attention remains fierce. So do we have any better alternatives? I look forward to hearing what you have to say. Thank you. Water. Okay, it's time for a few questions. Yeah, let me just get my water here. Yeah.
You don't have to go to the water. Thank you very much for the wonderful talk.
Question?
And now that we know that we can't choose, there's no way to choose. I'm getting up in age. So I said, what am I going to do? But you can't choose. But you can't choose. You can't choose. University towns. I know what
This was just great. And it raises so many, really fascinating questions. I had this thought, sort of news you can't use, and the collection of this data. Who's it for? What does it do? It reminded me a little bit, as you were talking, Nancy, of the story about the Toyota assembly line. And I think a lot of people have probably heard this, where they said to the workers on the Toyota assembly line, if there's anything going wrong, if there's anything any reason you want to stop it, anyone on the assembly line can pull the rope and stop the assembly line. And what Toyota was really doing was to try to figure out how fast they could really run it. So in this way, I wonder about, patient consumer data. I find myself, with the notion being very cynical about what they're collecting and for what purpose, and that the notion in medical markets of patient consumers who are sick, stressed out, have very little control about so many of the choices. So the question that I really have is sort of, is there a notion of what this is really for? Like in the audit culture, was it ever really to improve the quality of care? And there are many different sort of markers of quality of care. Or was it really about big payers, getting concerned about how fast the assembly line was running. Like, I filled out a lot of these surveys. How long did you wait?
Yeah, right. Yeah. I share your skepticism and your cynicism. I too. When you read the kind of larger discussions of the economization of everything, the Toyota that the parallels between a Toyota factory and your doctor's office, they're not that far-fetched. But I have to say that I can't, what are they doing it for? A lot of what they're doing it, I think there are many different motivations here for the people who actually do the research. They really think this works. They're primarily from economics, computer science. There's a love affair with big data, period, that all we have to do is crunch it a little bit and we can fix things. And they're true believers. I think the people who, are really pulling the strings don't care. But I met, I don't know if any of you knew Paul Cleary when he was at Harvard. He's now at Yale. These are people I've worked with at the Robert Wood Johnson. Mark Schlesinger is a really committed person, and this is what he does.
Yes, and I think they have good intent and good politics, but I sometimes find myself asking the question is, like, who's paying for it and who's really benefiting
Yeah.
from it?
And honestly, those are the kind of questions that I want to ask, but I've got to kind of try to understand what they thought they were doing. But anyway, yeah.
Yeah, please.
When you talk about the importance of narrative as a valuable way of allowing us to understand what actually happens between the sick person and the doctor, I think that is probably the least valued in all of this effort at. And I kind of feel like we've ceded all the ground when we start changing that dyad or that team and person in need by labeling that person a consumer. That notion immediately put us into an economic relationship that may distort the possibility of figuring out what quality means. So I'm concerned about fundamental language in how we
strongly suggest you read my book. I don't usually say that, but the idea that none of these problems existed before we started calling patients consumers is just not true.
No,
The
I don't
problems
think
were
that.
there. Well,
I don't think we can go forward
okay.
unless we say
Right.
we've ceded this ground. Because frankly, I don't know what we would call one another. It's not like I have a different answer or I think there was a golden age. I just think that the universal ceding to an economic vision
Okay, I totally agree.
and that's not using our imaginations
Yeah.
in a different way, because fundamentally, however you talk about this relationship, it's about a power imbalance that that is not acknowledged when you talk about a consumer. Oh, just go buy a different toaster.
See, you put I think part of the logic in this market model is you portray consumers as being on the same level as the doctor, which is just, even economists will tell you, no, never been that way, never going to be that way. I don't decide when I need to go to the hospital. I don't write my own prescriptions. There is a power relationship it's like going to buy. I completely agree with that. I think the difficulty is that we have economized everything about our society. We've economized the university. We've economized, it's just what is left to push back against as a kind of alternative. You just get clobbered with this, well, if it costs a lot of money, you've got to explain why you're spending the money. And, a lot of the discussion, this all started, it was to control costs. The part about quality only got tagged on at the end of it. I mean, originally, if the big push was to lower the costs. And then somebody said, wait a minute, if you don't think about the quality, what is the point of doing this? So yes, I agree with you. I just don't know where that language is. I don't think it's in bioethics. That doesn't seem to be, I get myself really depressed thinking about it. Although I try to sort of, stay.
Not knowing that economics was one of the spectrum in academia. Today, economists pretty much go everywhere.
Yes, they do.
So it has changed, the
Yep.
perspective and what we look at, how we look at it. Then finally, you want to find out who's a good doctor and go to Scott and say, hey, Scott, who's
I
the
go
guy?
to I do too. I go to another.
That's how it works fine.
Yep.
That's human being. We look to peers, we look at society. We are a group animal, that's how we live. And that's what it is. So when you have to go through searching all these criteria and stuff, okay, that's another question.
Yes, yeah.
I liked your presentation very much. What I get from it is a nice review of where we were in the early 20th century, 60s, 90s. And we're in 2018, and people several generations below me act on social media every day. The term going viral means somebody says, I didn't like that doc, and I didn't get treated well, and everyone in that area knows immediately. So I think that's the current state of things, that people pick up from their friends, from word of mouth, and they put it right on social media without a filter. And the judgment, as I read it, doesn't look very good. It's not based on, was this really a tough case, or was it an easy case? It's just, I didn't get treated well. Or, in fact, a complaint gets 10 people, and a compliment gets one person. That's what I see on social media, and I think those people not only aren't number crunchers, they don't read. So my second point is, for those who do read, a very exciting area seems to be coming around, and I see it more and more in the New York Times Magazine, in the Globe Magazine. It's an article by a medical journalism writer about a really tough case, about a really good detective story. And I think that for people who are wondering what does care mean, they may see something from Alpha to Omega and say, gee, that really was a long piece of care. I wonder if I get anything like that. But again, that's only for people who read.
I have a whole another talk that I do about the internet and how the internet has changed this conversation. But I find I don't buy the argument that the internet changed everything, because a lot of the problems have been magnified were there. You could get bad word of mouth. The sort of classic thing is that somebody at the Bridge Club said you were a crappy doctor, and you were really. So I think that problem of how to evaluate anecdotal likes and dislikes, but I agree with you. It's being magnified through these unfiltered measures. At the same time, people, even young people, kind of realize that, 2016 election may not suggest it, but there is a sense that you can't believe everything that is out there unless you are programmed to believe it. So it could be that in time, I'm not sure that everyone is going to start just using the bashing of a particular person on the internet.
Okay, so two hands here, so we'll go with 2 questions and we'll stop.
Hi, Nancy, I was thinking a lot about what we tried to do in the women's health movement in the late 60s and early 70s, and we really did care about quality, but we did exactly what this gentleman was talking about before there was an internet, which is that in the group that I was part of in New York, we kept lists
Yes.
of bad doctors.
Yes.
And people could come into our office and look at the data sets a little bit, and a lot of it had to do with, bad care or sexism or not, listening to what a woman said. So I think, in terms of all of that, both the stuff that was being done in alternative clinics, the work of the Panthers, and the Young Lords in New York, and of the women's health movement, I think also was an attempt to try to create both alternatives, but also to talk about how to share, how to even the power out. And it was an attempt to give patients and consumers a kind of data. And we did do that kind of stuff. I tell my students this and they laugh hysterically. A friend of mine and I did a pamphlet called How to Get Through the Maze with Your Feet in the Stirrups, which was a guide to women's health care below 14th Street, in New York. And I went to all of these free clinics.
Well, there were a lot of
and
consumer
pretended to have these
directories.
sections so that we could measure what. And we had a questionnaire. We looked at what happened, how we were treated, blah, 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 to give people a data set that we could give out. So I think it was an attempt, I think, at that. So I just was thinking in terms of the mega-analysis, you mentioned the sort of consumer movement. I think there was a lot of that.
Again, that's something in a 40-minute talk.
Yeah, I know, I realized that. I just wanted to make sure it got in.
Well, that there was an attempt to do a lot of this in the 1970s, but the kind of bureaucratic dead hand of kind of comes in, and also they hit the wall starting in the mid-1970s, late 1970s, that it's really hard. I think those initiatives continue, but they also are still getting ignored by policy experts to the detriment of those policy discussions. Absolutely.
That's right. And I also, this one other thing, I think it's also that the feds, at least certain groups of the feds in the 70s, really did take seriously the idea of consumer. So the group that I was part of, we had a grant from NIMH to study community involvement in community mental health centers. And we did 6 site visits all over the country. And we got a place in Minneapolis actually defunded because of the crop they were pulling. So at least I think there was at that moment in certain sectors a willingness to look at those things as really important.
Thank you. I was for that. One of the things in that is we still are struggling to find out what to measure, how to measure, how to analyze, and how to present so somebody will care to see it and then understand. So that's right.
I agree.
I guess my comment, so I work at Children's in the ICU, a very specific patient that I'm seeing, and it's also in parents, obviously, that are filling out surveys about their children. But the children are who you're caring for. And so I just find it interesting with what various organizations are doing with this data. And I think there certainly should be less of a power dynamic, and I'm not arguing we should be paternalistic, but I do find that to some degree it's going a little bit far in the opposite direction. So we have these family-centered rounds and family-centered care, so much so that it often ends up being just parent-driven care and parent-driven rounds. So I will just specifically not order antibiotic because a parent says, I don't want it. And even though it's what the child needs, and we have children I can't send to certain hospitals because their parents just say no. And so it's an interesting, but you're evaluated on that. And so I certainly want to empower people to be part of their care, but at least in the pediatric world, I've worked at several different hospitals. It's just interesting how it sometimes gets a little bit hard to do your job as a result.
Good, yeah.
Yeah.
I was on the other side of that experience. I was a parent of a child with a critical illness, and I was part of a family-centered care advisory board. And what you're describing is what we were working really hard to ensure didn't happen, because the physicians and the professionals are the medical team, but the parent and the child were the other side of this partnership. So in order to have the follow-up and the home care given, the family had to be brought to the table. But it wasn't like a power struggle. It had to be, all right, this is the science, and this is what has to happen to save your child. And understanding that, then the family's more likely to buy into it and better outcomes. But I never thought of myself as a consumer. It was, I'm part of the team. We all have the same goal, to get the child well. So I'm sorry to hear that.
It's not always
But-
Michelle Beckler, but it is interesting having to watch the evolution.
Right.
Another perspective of that issue, what the physician or the expert does is, what is the patient, consumer, or whatever other word you use does. I'm an orthopedic surgeon. A lot of things are elective in orthopedic and total health.
That's right.
She might have it, another person with a similar condition may not have it. But there are patients who come to me and say, you're the doc, tell me what I should do. And I'm saying, I'm only the doc. You're attached to your body 24 hours a day. Your wife knows you all the time, or daughter or husband or whatever. And so I need you to tell me what it is. And you usually take 2 or 3 visits before I can figure out where exactly they wanted to go. And some of the families that have a rule that 5 of us could sit at one time and talk. So it's a constant challenge on who's doing how much and what to achieve the goal that is common for all. But then how to get the things together is a challenge.
I guess because what you're talking about, trying to develop a working relationship, I mean, there's a whole nother world of decision aids and trying to teach in these difficult situations or whatever that people are also trying to do unsuccessfully, successfully, but at least they're trying. I personally would rather see my taxpayer dollars go into into trying to improve the team-making capacities of having more people to help explain or mediate some of that information than creating these bloody databases that would have helped you maybe choose this hospital versus that hospital, but somehow I guess I end up thinking that's not really the place to be putting our energy, but try to unhook it. It again, it's so built into this economic model of how you show you are being responsible. I don't know. It's very frustrating.
Thank you, Nancy.
Yes.